Well, I'm really honored to be here. I really wanted to include the British and American spelling of orthopedics, so any orthopedic surgeon would not get mad at me. I really have no idea when to use it, and so when to not use it. And so kind of the same thing I was telling Jennifer, like is there any anesthesiologists here? Or anesthesiologists here? So I just want to make sure I do things right. Like I said, I'm a family doc, and before I begin, I'm really grateful for Summit. They've taken care of a lot of our patients. They've done an incredible job. A lot of physical therapists here have taken care of a lot of our patients and a lot of my family as well. Gary Edwards operated on my knee. Dr. Pitts gave my dad a new hip. I'm sure John will operate on our backs eventually. And so, you guys have done a wonderful job, so thank you for all you've done. I was asked to give a little bit of background on my family. My Uncle Mike is here, so can you just correct me if I'm saying anything wrong? I will dramatize it to make it sound better. But so this is kind of the Sundwall family medicine tradition. We've been practicing in Utah Valley for over 100 years. So I had no pressure to become a doctor. So 1918, Olaf Sundwall actually set up shop in Lehi, Utah on Main Street. And then he was joined by his nephew, Dr. Peter Val Sundwall. He went by Val in Lehi, and then Val moved and went up to Murray. And then my grandfather, so that was my great-grandfather, my grandfather in 1970 also was a GP. I don't think family medicine was even a thing back then. And he joined his dad in Murray, but previous to that, he was down in Kanab, Utah, and practiced there for 10 years as the only doc there for a while. And then my dad actually came in around 97, and he actually established the Lehi Clinic on Main Street just a few blocks away from when they initially established in 1918. So, kind of cool. I grew up hearing crazy stories of old-time, good rural family medicine. Oh, I'm just talking about you. So, did you ride your motorcycle here today? Yeah. So I remember growing up, and that was my father right there. So yeah, here's your picture. You don't look different at all. So it's the same thing. So I remember growing up just hearing these old-time family medicine stories, particularly from my grandpa. I don't think Dr. John Edwards is here, but he'd probably have something to say about a few of these stories. But I remember, I think a guy in Kanab, Utah, 1970s, fell off a horse, probably filming a movie down there, had some cerebral edema. I think he had a subdural and had increased brain pressure, right? So one of his pupils was blown. My grandpa's the only doc down there. He's like, well, I think we got to do trepanation, which means drill a hole in the skull. Probably didn't have a lot of training, so he called, I think, Salt Lake at the time, University of Utah, the only neurosurgeon that was available, and he walked him through how to drill a guy's hole. He cleaned off the drill and probably got a wipe off of his own drill and drilled a hole, and the guy survived after they life-flighted him back up there. All right, I got to tell this story just real fast. I promise I'll get to the presentation, but another story of him was, so it's this guy right here, but another story of him was in, I think it was, so a lady had gone into labor. She was hemorrhaging. They needed to do an emergency C-section. So my grandpa's doing the C-section. She continues to lose blood. She needs a blood transfusion. The only person that had the same blood type as her was my grandpa, who's doing the surgery. And so he is transfusing his own blood into her as he is operating on her. And I guess 20 or so years later, 20, 30 years later, I think my grandpa's at church or something, and a guy comes up and says to him, hey, you gave me this scar, and he shows him this huge scar right on his cheek. And my grandpa's like, oh, sorry, I didn't mean to do, what did I do? He's like, well, actually, I'm named after you, and you saved my mom and my life as well. And So as my grandpa was operating, he actually just nicked the baby as he was hurrying up, and he gave that baby a scar. And that was just kind of, he was the lifeblood of that family for the rest of their lives. And so those are the stories I remember hearing. And same stories even from my dad practicing in Lehigh, just kind of interesting, crazy, old school family medicine. That is not how we practice today. I do not transfuse my own patients' blood. Okay. I'm grateful for the specialists that we have and the opportunity we have to work with them. I think this video kind of sums up kind of what I was saying here. Do you guys know who Dr. Glockenflecken is?
Yes.
So, all right. Yes. Let's see if.
Family medicine. How was your day? That's pretty good. Anything interesting? I delivered a baby. Well, that's exciting. I have been in 3 patients in the hospital. Oh, okay. Sounds like a very productive. I discharged 2 patients. I called 6 consults. I completed 8 prior authorizations. I saw 30 adults and 10 kids in clinic. And I went to a quality improvement committee meeting. And I stayed awake. That's quite a day. Yeah, and now I get to go home for some family time. Work-life balance, that's wonderful to hear. Oh no, I called the charts I have to complete at home, my children. Tonight I have 25 children. Family medicine. This is not healthy.
All right. So there is some truth to that. I will say, nowadays I think the scariest thing you can have is a family doc that feels like they can actually do everything and anything. We know our limits, and we're happy to send people to physical therapy and orthopedics and everyone else. So I just want to say I love family medicine. I think it's awesome, and it continues to show that it does. Patients that are established with a good family doc, lower mortality, decrease ED rates, decrease hospital admissions and readmissions, all right? And even with orthopedic problems. Most of the time, patients that go to the emergency room with orthopedic problems, they could have been managed in an appropriate set of primary care setting. These kind of studies say that. All right, so these are my disclosures. I really would like to have a disclosure one day. That'd be pretty awesome. I would love to get some extra income some way, somehow, instead of getting paid from hospital coupons or something, cafeteria coupons, I don't know. And so these are my objectives. So I will end on time, all right? Sundwalls are really good at ending on time. We feel like zero information gets passed on if we go over time, all right? So no one pays attention, let's be honest. So I will end on time. But I want all of us to understand the role of a family medicine physician in an orthopedic patient and identify the obstacles of a patient and the primary care physician, I guess all of us face during a visit. I really want to understand the logistics that a patient undergoes as they get a workup done and how we can improve multi-specialty communication between physical therapists, chiropractors, specialists, etc. And then we want to really touch on supporting the providers in every specialty and how to make each other better. So this is the case. And as we go through, I know we all kind of come from different backgrounds. I want us to envision us as their primary care doctor. So I just want you to think about you are the family doc, okay? Just put yourself in that situation as best you can. So a 52-year-old, successful guy, he owns his own construction company. He comes in for a follow-up of blood pressure, weight loss management, insomnia, anxiety, depression. Haley, what else do they usually come in at the same time with? Yeah, she's a PA, she understands. That's kind of how it goes in her clinic. So during the visit, we discuss his lifestyle, review his medical weight loss management, hashtag Ozempic revolution. We adjust his blood pressure medications. Jennifer, don't get mad at me for bringing up Ozempic, okay? It's a good deal. We try to minimize his Ambien use, and I also listened to a recent experience of him having to fire like half his company due to the economy and everything. So at the end of the visit, he states, "Oh doc, one more thing. My left knee seems to have swollen up." And he lifts up his pant leg, and you see this. Remember, you're the family med doc. Okay. One of these things doesn't look like the other, right? So, what do we do next? What is the next step? Granted, we're about 45 minutes behind in clinic. What do we want to do? And I know I want to get some involvement here. can you just look at the person next to you and talk to them and just kind of go through these choices and see what you guys would think and what you would do as the primary care doc? Can you guys see those? Right there. So there's a huge glare. I don't know how to do that. I don't know if you can see it. Is there like the video? Can you see it at all? You can stand up and look over.
Start with x-rays.
All right. Okay, so let's work through these. None of these are the wrong answer. All right, there's probably a lot more options out there that you could do too. I know there's somebody out there that says, "How dare you not put up this answer? This is the right one." Okay, we're just going to go through these. There's no right way to go about it. So send for imaging. Who would say that would be a good option for this patient? Anybody? Oh, okay. Oh, Reyes? Yeah, I'm sure they would. Yeah, I'm sure Reyes would be a good idea. Okay, I like that. Good. I don't think that's the wrong answer, right? We don't really know what happened to his knee. Did he fall? Did it swell up? Does he need an x-ray? Does he need a cash pay MRI? Because everyone thinks they need an MRI now. Let's just bypass all insurance, all that stuff. We have a high deductible plan, right? We know how that goes. So, all right, so not a wrong answer. All right, send to physical therapy and follow up with orthopedics. Is that basically everybody else in this room feels like that's a good idea? Yeah, no. What do you guys think about that? Is that reasonable? Maybe, right?
I don't want that knee in my office.
You don't want it in your office, right? You don't want that red.
She's going to go somewhere else.
Okay. Okay. All right. You're already behind. Make a follow-up tomorrow. Throw some ice on it. Give him some ibuprofen. Maybe give him a prescription of an NSAID to make him feel really good. What do you guys think? Is that reasonable? You're 45 minutes behind. All right. Would somebody do that? I think I've probably done that sometime in my life. Okay, probably when that happened. All right, and then here's the board answer, right? The board question answer: get more history, right? You do the least invasive, you get more history. All right, who wants to do that? Yeah. Okay, we all do. Okay, so we decide to get more history. So he really can't think of an injury. It started swelling last night. He can't think of any systemic symptoms that are kind of going on. He does have a history of gout. He's had no surgeries. There's no hardware in there. Some family history, dementia, vital signs. His blood pressure's up a bit, but he's afebrile. Heart rate's maybe up a bit. On presentation, he acts pretty good. He's very pleasant. I mean, you just had a whole conversation with him, not about an orthopedic problem whatsoever. So it was kind of like later on his mind. But the exam kind of shows what the picture was showing. So the left knee's edematous is red, it's hot, there's limited range of motion, he is intact, the joint above and below the knee is fine. Any orthopedics here? Is there anybody here? So Pitt said he was here. I put some stuff in to really prove that I knew what I was talking about, but I'm really mad. So a joint above and below is fine, the adjacent knee's unremarkable, all right? So let's talk about what do we do next? So what's the next step? All right, so let's talk to your partners again and let's just kind of see what you guys would do. So choice A, he's got a previous history of gout, so you treat gout and you just want to have close follow-up within 24 hours. Who thinks that would be a good idea? Or your thoughts on it? He does have a past medical history of gout. Is that reasonable? Anybody have any questions on what the treatment for gout is, usually? Elevate, ice, NSAIDs, colchicine, and then our favorite, steroids, right? That's our favorite. We always give them steroids. No, so previous history of gout, so you want to treat gout. Would that be a reasonable thing to do for a swollen joint? And the answer is actually probably, in a lot of cases, especially as a past medical history of it, okay? Obtain lab work and imaging. Please don't comment, Reyes. And then, so what about lab work? What about that? So anybody want to get some lab work? Uric acid? Great. Yeah. Any other labs?
Blood cells too, in case he's got cellulitis
Great.
or something.
Great. Yeah. So you want to make sure it's not infectious, right? A CRP, which is an inflammatory factor. Now, you're in the outpatient setting, right? You're not. So yeah, so that's the problem, right? That's where we're kind of coming into a logistic problem where, okay, so do you get labs right away in the office? Because if you get them in the office, the lab comes at the end of the day, picks them up, sends them to the lab. You get the labs back in whenever, right? I just found out with our clinic, how long does it take for our CRP to come back, which is an acute phase lab? 10 days. All right. Is that helpful at all? No, not at all. But there's another option to get labs. One is you send them to the hospital, you do a stat lab, right, and get it back hopefully by the end of the day, really, within that next morning. So there are options there. So not a bad idea, maybe. I mean, an x-ray is not a bad idea, right? Just to make sure, hey, did he fall? Is he not explaining that? He's a construction company owner, right? We can just totally stereotype him and put him in that situation like he probably fell, he didn't want to tell anybody, okay? So C, perform an arthrocentesis. So anybody want to stick a needle in the joint, a red hot joint? Anybody want to do that? No? Okay. All right. Why would somebody want to do that? Get a diagnosis? Yeah. Do we know that it's really gout? Do we think it's infectious joint? Right. Yeah. Because the fluid could actually be very helpful to actually look and see what it is. The problem with that is, what do we do if we think it's an infectious joint or gout? We get the fluid, we look at it, and then what? We send it to the lab. When does that come back? Right? Right? If it's an infection, he's already lost his leg, etc. But we'll see how this goes. So now, okay, D, send to the ED and notify orthopedics. Is that ever a wrong answer in the outpatient setting? No, it never is. So, any thoughts on the last answer choice? Send to the emergency room and just notify orthopedics. What would I be worried about, or what would we be worried about if we decided to do that? Infectious joint, right? Yeah, infectious joint. So, septic arthritis. So this is what you decide to do. Because you're a new, younger family doc that's cautious kind of about everything, you recommend the ER because you're worried about an infection, okay? So you tell him that. He's a tough guy. He's got a high deductible plan. It's like, but I feel fine, all right? It's gout. I've had gout. I've never had it in my knee, but I've had it in my big toe. Just give me some prednisone. It's worked in the past. I really don't want to walk into the ER, pay $2,000 just to walk in so I can get that prednisone prescription, which really is only $5, right? And you're like, okay. And what do you do next? And I'll just kind of move through. So what do we want to do the next step? Do we just say, yeah, okay, let's try it. You said you wanted to do it. We treat for gout. What do we think? Patient would be happy? Is that reasonable?
Just get out your checkbook.
Get out your checkbook?
For your lawyer.
Oh yeah, so yeah, medical malpractice. Right there? Yeah. Pay his salary right now? Okay, all right. Arthrocentesis again, lab work and imaging, send to orthopedics. So let me just, let me actually work through these since this is interesting. So arthrocentesis, I think it's more so the diagnosis is important, right? There's also another aspect to this, and it's how do we convince the patient to do what we want them to do? And so he didn't want to leave the clinic, okay? So he doesn't want to leave. He doesn't even want to go to the hospital to get labs, stat labs. He's like, look, it's fine. What's the deal, all right? And we're like, well, maybe we can call orthopedics. We call, we call Dr. Pitts and say like, hey, can we get this guy in really quick? I just want you to look at him, make sure I'm not missing anything. What do we do? And so I convince him we convince him to actually tap the joint, all right? To actually do an arthrocentesis to try and get a diagnosis, because he's not leaving. He's like, you give me some medicine, and I'm like, okay, well, it's a swollen joint. How about we convince you if we took off some fluid, it would make it feel better, because it is starting, like he's realizing actually it does kind of hurt, It's like, oh, okay, make it feel better, we'll take off some fluid. So that's actually what we do. We decide to take it off. And that's always risky, right? You're in the outpatient setting. He could have an infection, which is what you're like the worst case scenario that you're thinking about, and you're going to stick a needle in an infectious joint, that's always kind of nerve-wracking a bit, right? Because you're like, oh, I'm just going to, here's some staph. Let's give you more staph, right? And so, all right? So always scary to do that. But you do decide to do it because that is the next course of action based on any up-to-date article or any other article that we want to read, is say, like, you figure out the diagnosis. So you do. And so you get this fluid. What does it look like? Normal knee fluid, right? This is exactly what synovial fluid looks like, okay? All right. Yeah. Could gout look like this? Kind of, actually. It could be milky, but not really, okay? So now we look at it, we see it, we're like, oh man, I'm really worried about an infectious joint here, all right? So what do you recommend? Go to the ER. So a septic joint is an orthopedic emergency, so you do send them to the ER. So right now we're like an hour in or longer into this appointment. Your patients are behind. You piss off your PA. It's like, can you see a few of my patients, right? To get them going. And so you're kind of stuck in the situation, but this is kind of getting a little serious. But he still won't go. He's like, look, it looks like an infection. He's like, yeah, but it doesn't hurt. I feel good. I'm fine. So you're like, okay, I'll get labs. Maybe miraculously they'll come back in a day. All right, maybe we can speed it up. He's afebrile. Maybe he'll be all right. I call Dr. Pitts and say, hey, can we get this guy in at least tomorrow? Because right now we're looking like 4:30, 4:45 at the end of the day. And he's open to that. He's like, yeah, I'll see somebody if it's still a problem tomorrow. Like, he thinks it's going to not be a problem. All right. I did give him, we did give him some Rocephin just to cover it. So I injected him, right? We don't have IVs. We don't have any of that. I can't wash out his joint right there in the office. I just give him 1 gram Rocephin to keep him at bay, all right? Now, I know an orthopedic surgeon here is going to be like, don't do that, and I send off the culture. And do we do close follow-up in clinic? Well, not really. I want him to go. I want him out of my office. All right? I don't want him to come back. I really don't. I don't want a malpractice suit here. Okay? But most importantly, we care for the patient the most. All right, so case conclusion. He continues to go to the ER. You get labs, and you do send it for synovial fluid culture. You give him a shot, and he gets an appointment with orthopedics the next day. Dr. Pitts is like, well, you think it's a septic joint? You're going to send him to my office? I'm like, yeah, I know. Like, he won't go to the ER. If you tell him to go, he'll go, all right? I promise, all right? And that's very common in primary care, all right? If we're telling them to do something and they say no, I'm like, well, can you have like neurosurgery or orthopedics tell them to go to the ER? They'll go. It's just the nature of the game, it's cool. Then they come back to me and say, they said to go to the ER. Can you believe that? How come you didn't tell me that? Yeah, so it's all right. So case conclusion. So the next day, the joint continues to worsen. It's more edematous, red and hot. Orthopedics is super mad because they asked for the labs, which the PCP got, which are not back. I got that 9 days later. All right. Orthopedic sends the patient to the ER, and he agrees at this point. Because it did worsen, he wasn't actually feeling super good at that point. He's scheduled for that day for an IND. He has MSSA, septic arthritis, which is methicillin-sensitive Staph aureus. All right. He calls you and asks you, though, I think this is kind of a key point. Patients will follow up with the primary care doc because they trust him and say, hey, he did say surgery. Should I do surgery? And you say, heck yeah, go do the freaking surgery, okay? So, and he does. And he actually does really, really good. So these are my take-home points, and it's tricky, all right? Every patient's tricky. All of us kind of go through all this. I will say, another plug-in for family medicine, we do give you business, so really treat us nicely. I think the worst thing that we ever get from any specialist is, why are you here? All right, I'm sure neurosurgery gets patients from our clinic all the time that's like, what the freak, you don't have an MRI, what are you doing here, you don't have x-rays, or why didn't you come to us earlier? If you say that to a patient, gosh, it really sucks for us because we don't really know the situation. And that's the same for like the specialists, the ER, or physical therapy. Like, you guys get all sorts of different information from the patient, and like we don't really know what really did happen, right? And so that is like so helpful to know, like, oh man, like, I'm sorry you're here, let's work you up, let's do it. And then if we did make a mistake, and I think that's my last point, if there was any mismanagement from the primary care, we would love to know how we could have done it, or we can give you more of the story and how it did. Like, call us, let us know, okay? That would be awesome, even from a physical therapy standpoint. Like, hey, it would be great if they had some imaging, or they didn't have some imaging. Did you try this first? Like, that would be awesome, and we would gladly do the same thing. I think we deal with obstacles that may not be apparent to other providers and vice versa, right? We don't really know what kind of went on. Understand the logistics of workup. I think it goes along with like the labs. I think for me, I didn't realize the CRP would take that long. I was hoping maybe it would come back. I could have been more pushing forward to like, hey, at least get stat labs in the hospital or something. Maybe he'd be more willing to do that. I think big with the logistics too is insurance, right? Like, well, yeah, okay, you need to get this imaging. It's going to take a week, right? It's going to take a long time to get it. And you're like, oh, well, so setting expectations is a big deal. And then early communication, right? I came up with this saying, many minds, better outcomes. So I thought it was really good. Kind of rolled off the tongue really, really well. I thought it was great. So that is your, yeah, okay, all right. And then, yeah, we're all in this, we're trying to help each provider learn. Like, we all want to get better. We all want to take care of patients. None of us want to get sued, but we really want to take care of patients, right? And I love a call. Like, so after all this situation, this was a real case, and Dr. Pitts was a part of it, and I asked him, like, hey, like, what could I have done better? And he's like, well, it would have been nice to have those labs back really quickly, because then that would help make the decision. And so I think back on it, like, I could have really pushed, like, hey, just go to the lab at the hospital. It's easy, it's quick, it's not that big of a deal. We can get those labs back a lot faster. So, but I really appreciated that. He didn't say to the patient, like, gosh, your primary screwed up. You shouldn't have done this, right? Because that really discredits, I think, kind of the whole healthcare system, right? It doesn't make anybody look good. So those are kind of my main things that I wanted to bring up. The last thing I have to share this photo. It's kind of going back to my family. I swear, my dad and my grandpa had this ability to, or you have this ability, sorry, you're not passed yet, so yeah, you're not retired. Yeah, have this ability, I swear they can say to a patient, you know what, you should just go to hell. And that patient could be like, thank you so much. That means a lot to me. And I don't know how they do it. It's crazy. So this is just another tribute to my grandpa here. So this is how you know you've made it in life and as a provider, right? This is literally a patient with a tattoo of my grandpa's name on it for saving his life, tattooed to his arm. I love that picture. I think family medicine, all providers, all of us have such a huge impact on our patients' lives. And I think it's how we go about it and how we express that to them and communicate to them. And we really do save their life. I know the ins and outs of every day are just really rough, and we are 45 minutes behind. We're always behind. But I do know that we can stay on time. We can provide better care if we really do care about the patient, right? That's that classic Harvard professor that said the best way to do patient care is to care for the patient, right? So I love that saying. So thanks for being here. I really appreciate it. Happy to talk about any questions after, but thank you very much.